Thanks for having me here at the conference too. My name is Jay Granzo, and I'm a lymphedema and lipedema surgeon. For me, this is always a team effort, and that's what I'll talk about today too. It's not just about me performing some procedure and sending the patient on their way, or trying to do as many procedures as I can each week. It's a team effort, and everything's very individualized, and I can't work alone. All the wonderful people I have here, and I have Sam and Non here with me also, are integral in our success stories for our patients here. So everyone performs a crucial role that I can't work without. Here are some of the team in Florida. So we recently, over the last 2 years now, moved from the LA area over to Florida. We're settled in there, so we see all new patients in Florida. Everything is essentially Florida-based, and here's some of the team there. We have a big back office working on all the billing and insurance items. That's just as many or more people that are now based virtually otherwise. And we bring our team into the hospital too. So most of my patients, or most of my cases, I will actually perform in the hospital. It allows us, and I'll go over that briefly, to perform and take care of the patients in fewer surgeries and get more done at one time. This is the other team at home. That's very important. We moved to Florida primarily because my daughter's Angelman syndrome. She goes to a special school now. And so they all look like angels there, but this is, took about 50 of those pictures to get that one. There's another one, yeah. So, yeah, they're more normal, hopefully, yeah. My background here, just a bit, I've been a plastic reconstructive surgeon for a long time, board certified 2006. I had a microvascular surgery fellowship, and I was on faculty as a full-time faculty up to the rank of full professor until I retired in 2020 because of family issues. So at this point, my practice is limited to lymphedema and lipedema surgery, essentially entirely. Key points for how we take care of patients. One is, we all know lipedema is a complex disease process. I think that doing something by rote and not customizing it per patient will not get you the best results. The key part is a comprehensive system that includes both the non-surgical, which we just heard about with the compression, for example, and the surgical components. Each patient's treatment plan is individualized, and we spend a lot of time with the patients, both on the phone before they ever come. We do imaging, and we spend a lot of time with them at that initial visit to make sure that we have the proper and best treatment protocol that's going to work best for that patient. Again, what's critical for me also is, since I treat a lot of lymphedema, lipedema needs to be differentiated from lipedema. And the overlap is a lot more than I had appreciated first. It's probably 5 to 10% of the patients come in with lymphedema that we find on imaging or an exam, and the outcomes and the treatment, we can treat that very well too, but the treatment pathways are going to be quite different. The outcomes and expectations are going to be somewhat different. We can still get great results, but if you were to treat a lymphedema patient with, say, a lipedema protocol, then you'll have excess swelling, other things that are uncontrolled. You'll have outcomes that will be suboptimal or poor. At least that's in my hands. A note here too, there are a lot of esteemed colleagues here. These are the things that work for us. So I know everyone has a different approach, and I very much respect those approaches. For us, what's key to our approach is the therapy component. So you won't be able to come to my office and not see a therapist. It's all included in the overall cost, treatment plan, everything, because I feel it's such a critical part. Therapists come right in the OR, we bandage right on the table to keep that swelling down right from the beginning and to keep that from coming back up. I think the results do make a big difference. We have had patients, again, we try and minimize that, who have not been compliant with the therapy, and they tend to do worse, actually almost always do worse. And that's too when someone will stumble in, having been treated elsewhere, wherever it is. Almost always they have not had the therapy component as one of their problem areas. So there are a lot of bandages. These are flatten it, not ACE wraps, for example, and the therapist will take care of that for me. So here's looks like we're cut off on the top of the screen for the formatting, but this is a lipedema patient who had liposuction elsewhere. I like to do things and really get those legs down one at a time. She actually had that not really knowing she had lipedema before. I think and she felt that the surgeon didn't do a good job. Really didn't do it. My pain only went down a little bit, my swing, well, I think it was protective actually to some extent, and I think that the patient didn't know it, the surgeon didn't know it, and I think it still did help, but we'd like to not have her go through a couple of different procedures and get treated in one shot rather than having to come through here. I don't think anybody was doing a bad job necessarily, but we'd like to not have a patient have multiple procedures. So with us, for me in my hands, we typically take care of the patients in 1 to 2 procedures. Most patients 2. We'll do 1 leg at a time, take care of that whole leg. Why? Because then that leg will fit into those garments you just heard about. It will be a cone shape that is a uniform shape, and I can get up to 15,000 cc's per side, or at least we've had that before. Now, please don't test me on a 15,000 if we can, but certainly it's something that we can do very consistently, so you don't have to come back 3, 4, 5 times to get additional recoveries overall. Now, this is a low volume lipedema patient, so this is 3,400 cc's. Even that patient will hide a lot of stuff, but again, the appearance has improved a little bit, but her symptoms went down massively. So obviously that pain and those issues are very much improved. This is a more standard patient that we would see, something like this volume, where we take the one side down very consistently, bring the other side down, and here we have 17,000 cc's. We've gone up to 30,000 for both, so 30,000 is 60-something pounds of stuff. When you come to our office, we spend time with the patient each time, so I can't move through 8 surgeries a week for lipedema. It's just not how I function. It's just me. I take care of all the patients myself surgically with the assistance of my team. So expect to spend at least a half day in our office plus imaging to get that thorough approach, because we are really very compulsive about how we want our patients to be taken care of. Fortunately, we have a new training center here, and I was able to, in Florida, the economics being what they were, we were able to purchase our building. We also have a training center where lymphedema therapy is taught separately. That's a different talk for a different day. And again, I think the lipedema versus lymphedema is a key thing that I focus on a lot, because the outcomes are different. So sometimes it's very easy to differentiate them, the lymphedema patient with the one big leg compared to the lipedema patient. And sometimes it's not so easy to differentiate which one's which one has lipedema, and which one has lymphedema. And we'll sort that out, and we'll do the proper imaging and work up there too. So again, here's a lymphedema patient here. We can image that with an MRI scan. And again, we see, just like Dr. Wright was talking about too, that there's a lot of fluid that's in there, even in the parts of the patients. For example, this is the thigh, where clinically there's no fluid. If I push down on that patient, I don't find fluid. I can't get any pitting, but we can really see that over here, this is the opposite normal side. This is the stuff that's pathologic, and those white strands within those, within the gray matter, that's all fluid. Clinically, you can't feel it, but it's there, and this is a lymphedema patient. I think this is present in lipedema to a lesser extent, like Dr. Herbst was talking about, and all the other speakers too. Again, lymphoscintigraphy, very easy to differentiate one from another. These are 2 obvious examples. We can do it on ICG, which we offer in the office as well. And again, why is that different? Because the fat that you get out for different things, this is a cosmetic liposuction patient on the one side. That's, you get a nice, smooth, custardy type of aspirate. The lipedema patient's gonna be closer to that. The lipedema looks like lymphedema looks like curdled milk. You know, it's a very different outcome. So again, our goal is to treat things in 1 surgery for each leg, 1 recovery, and do it in a safe and consistent fashion. Thanks very much.